All right. All right. Good morning, everyone. Welcome to the MIT Roundtable Digital Pandemic Response in Africa. We put together this conference at the leadership of Professor Ramesh of MIT to sort of bring together experts from all over the continent to discuss ways of using technology innovation to respond to COVID in Africa. I know there's been a paradox in Africa. We have a very low case fatality rate, and people are wondering what is exactly going on in Africa. But of course, COVID is not over. There's still vaccinations and other issues to talk about. And that's the focus of this conference today, to bring all of us together to discuss and the next steps. Of course, to also see how we can adopt technologies like the PathCheck apps and the COVI-ID app to make sure that we can be on top of the game. So we have a lot of experts here, our partners from MIT Africa, PathCheck Foundation, CDC Africa, and COVI-ID. Let me give a big thank you to the organizers who have done an amazing job. Kungela, Deepti, Ari, Ramesh, you've all done a wonderful job to get us through far to this conference. So without much ado, I would hand over to Ari. Ari is the managing director of the MIT Africa Center, and he's going to take us through some of the things they are doing as MIT in Africa. Ari, please take it over.
All right, thank you, Dennis. Thank you all for making the time to be here today as we discuss opportunities and challenges to responding to the COVID-19 pandemic in Africa. And we have an exciting program for you today. And before we get started, I just wanted to offer a brief overview of what we're doing at the MIT Africa program. So as Dennis said, my name is Ari Jacobovits, and I'm the managing director of the MIT Africa program. MIT Africa program aims to deliver what I consider bidirectional value to the MIT student community and collaborators across Africa. And to students in the MIT community, we further MIT's educational objectives by creating applied international learning opportunities for MIT students in African countries that increase their ability to understand and address real-world problems and build strong, meaningful intercultural connections with their host countries. To collaborators, that is our partners in Africa, we seek to advance the research, education, and innovation goals of their Africa-based organizations. And we have 7 primary mechanisms that we use to deliver this value. The first are internships, that is MIT students intern with different companies based in Africa. And in a normal year, we have many traveling, around 100 per year. I know there are people on this call who previously hosted interns and have been wonderful hosts to our students. We offer another program we do is called Global Teaching Labs, so we embed students in high schools around Africa to lead workshops on STEM. We've been doing this now for many years and have had a lot of success. In fact, we embedded with the Ghanaian and Ugandan Math Olympiad teams just this past January, and they this summer at the International Math Olympiad had their best ever performance. So we were very excited about that. Ghana brought home its bronze. Dennis, did you hear about this? Ghana won a bronze medal at the International Math Olympiad this year.
Yes, we're so excited.
Okay, yeah. We're very excited too, and it's the beginning of something wonderful. And in addition to that, we have startup labs where we combine STEM and MIT's approach to entrepreneurship. We normally do that in partnership with universities. We have seed funds for faculty-to-faculty research collaborations. That is, an MIT faculty and a faculty member at a university in Africa can receive funding to begin a collaboration together. And we actually have a funding round that just opened. If anybody wants more information or details on that, I'm happy to provide, because they can apply to receive funding for those collaborations. We have study abroad opportunities that are more of a classic. Students spend a semester at an African university. Students in Africa spend a semester at MIT. We have events such as these and the MIT Africa Forum, which we host on a monthly basis. And we serve as an advisory role to the MIT administration on matters relating to Africa. In my final note is just consider MIT as a partner in your work in Africa, and please be in touch if you foresee an opportunity for collaboration. We are open for business and very excited to be engaging. So thank you for joining us today. And I will pass it back to, I believe, Dennis, or who is it? Who will,
He's going to take
Deepti.
you
I'll
from
pass
here.
it now back to Deepti to discuss where we go from here.
Okay. Thank you so much, Dennis and Ari, for the wonderful start and giving everyone an overview about this initiative. My name is Deepti Pahwa. I'm working with MIT Program for Trusted Pandemic Technologies for this MIT Africa Conference on External Partnership Event and Communications. As you all know, the focus of this event is to work with public health leaders as they design and deploy digital contact tracing and digital management of testing, vaccines, and health verification for COVID-19. Subsequent initiatives under consideration also include surveillance, monitoring, and predictive modeling. The aim for this conference is to set the context for conversations on how we as a society can move towards being better prepared for the current as well as the future pandemics. On that note, I would like to invite our first keynote speaker, Dr. Ramesh Raskar, who is a professor at MIT Media Labs and also founder of PathCheck Foundation. And he will be taking us through his presentation about the digital pandemic response. Ramesh, over to you.
Thank you, Deepti, and welcome everyone on digital response for COVID-19. I'm Ramesh Raskar, professor at MIT Media Lab, and also founder of the PathCheck Foundation that's creating open source, nonprofit, open standard solutions spun out of MIT. Now, when it comes to dealing with crisis, there are different ways to look at it. If you think about a hurricane or flooding versus a pandemic, in a hurricane, you have a top-down view. You have a National Weather Service that monitors the weather, has some prediction, and then you have a command and control based solution where the governments get together and they decide what the population should do. So it's a very top-down solution. When it comes to epidemics, unfortunately, it's innocent people infecting other innocent people. And in that sense, individuals themselves are sensors and stakeholders in this process. And so we need a bottom-up solution to understand the social behavior. And this is where phones can help. So the main point I want to make here is that to deal with epidemic, it's not enough to have a top-down command and control solution, but we should really think about a bottom-up solution that involves individuals. We'll talk a little bit about contact tracing, but the emphasis is on digital pandemic response. And smartphones, feature phones, and personal technology for exposure notification, case management, coordinating COVID-19 tests, addressing vaccine delivery, health verification, back to work efficiency, and maybe using this crisis as an opportunity to rethink digital public health. Now, everyone knows about exposure notification and case management. Using smartphone or other technology, compute the proximity between users, that's step one. Step two is notify if you have come in contact with somebody who might have been infected. Third is self-assess and diagnose, possibly on the smartphone. And then finally provide tools for public health and businesses to manage this. Now, what is MIT doing here? So MIT SafePaths, which was spun out of our lab, was the first one to launch a contact tracing app in the US. It was the first to propose the algorithm for decentralization that's completely privacy preserving. And also the first to write a policy paper on all the things that can go wrong. We called it the apps gone rogue, unintended consequences of deploying such technology. For misinformation, for fraud, for inclusivity, what happens if some have smartphones, some don't have smartphone, what if the population does not trust the government, and so on. So it was the first policy paper that's been referenced by many. We are the only contact tracing team that has been invited to present in front of US Congress, many international papers, and then we have launched a catalyzing platform, pandemic.mit.edu, to bring US and international communities to digitally address COVID-19 testing, vaccines, and economic emergence solutions. And then we also spun off PathCheck Foundation, which is a very well-funded nonprofit, has raised a few $1 million in nonprofit funding, and is helping many states and nations launch their apps. Again, as I said, it's become the world's largest open source nonprofit project for COVID-19 to create privacy-first, efficient solutions for public health and restarting economy. It's just humbling to see more than 2,000 people working together on this effort as part of this MIT spin-off nonprofit. And in that sense, we are working on not just the insights, the research and analysis and standards, but also building professional grade software and also providing professional services for US states and countries. So it's more than just a MIT research, and it's a full-fledged professional service through this nonprofit. I won't go into the detail, but most people think about dealing with contact tracing and case management in the left column, which is, if you look at the bottom left, it identify contacts, interview for context, and then test and isolate. But on the right, people who are techno-optimists, maybe too optimistic, think that they can solve all this problem purely digitally by creating apps and asking users to do everything on their own. And we think actually the best solution is the fusion of the two. The manual operation that governments will set up, as well as the digital solutions that citizens will be empowered with. Because for an individual, it's not just about exposure notification or even testing. They have a whole flow they have to go through. Do they quarantine or not? Do they get sick leave or not? Where should they go get testing? What does the result of the test mean? Because if you're exposed within the first 4 days, the results actually be negative, but you still have to quarantine. And what comes after your quarantine is over? Can you just go out and start socializing, or are there follow-up case managements and so on? So it's a pretty complex flow for an individual's point of view. And that's where smartphones and feature phones and QR codes can play a role. And again, some software company can come and just deploy the solution. It's not a big deal. The challenge is, how do you do this in a privacy preserving way? So even the people in the society who are at the margins, who don't trust the government, are wary of law enforcement, are willing to participate the way they're willing to participate with the banking system, for example. Extremely private, 1:1, and are not fearful of their personal freedom and liberty. And we have the same challenge with businesses as well about what does it mean to do testing, what's the workflow, and so on. So we think this forum would be a great conversation for not just individual users in public health, but as employers and tourism services want to use citizen-centric solutions, something that can run on the phones or feature phones or QR codes. How can we get them going for all this stuff beyond public health? So hopefully through this MIT Africa platform, we'll think about digital strategies, not just for exposure notification and symptoms, but for COVID-19 testing, its efficacy, hotspots, vaccine tracking, vaccine deployments. Some vaccine shots will require a second boost after 21 days or 28 days. How are we going to do that if we just do camps for vaccines like we would do for other infectious diseases? It's not going to work out. So we need a highly digital solution that's citizen-centric. So with that, let me thank you for joining us, and please download our apps from PathCheck Foundation and also join our catalyzing platform, pandemic.mit.edu. Welcome.
Thank you, Ramesh, for that presentation and how our bottom-up solutions are a must to contain this pandemic. That was really a great presentation on that. And all the work MIT and PathCheck has been doing during this pandemic, it was great to hear about that as well. So our second keynote speaker now is Dr. Ahmed Auma. He's Deputy Director of Africa CDC. He would like to take us through the work that CDC Africa is doing and the response to the pandemic. Is Dr. Ahmed is here, or would you take over Justin on his behalf?
Sure, Deepti. So I think Dr. Ahmed is not here, and Justin is going to take over from him. Justin is the head of surveillance and disease intelligence at the Africa CDC. So Justin, you are welcome, and you can take over.
Thank you, Tim, and thank you everyone for the participation. This is quite an exciting and very enthusiastic discussion, and I'm glad and happy to participate in this on behalf of the African Center for Disease Control and Prevention. So the Africa Center for Disease Control and Prevention is the public health agents of the continent. We are representing the 55 member states of the AU, and we have been working through since the beginning of this pandemic to support member states in all aspects, the innovations, the response and procurement supplies to ensure that they are up to speed to be able to respond to the pandemic. And through that, we have been pushing through different initiatives that are all meant to limit transmission within the continent. Also trying also to limit the impact of the pandemic itself to the economies and the livelihoods. As we speak now, we are running a campaign of saving lives, economies, and livelihood by ensuring that we have all the required resources and allowing different innovators and technologies to come together and support member states as they are opening their borders. All issues related to active case search, contact tracing, what they call activation of detection points. We know in Africa, we have also a different way on culture that when people get sick, there are several places where they visit to get the first care before they even visit what we call designated health facilities. So all these, we call them detection points. So we also work together with this to make sure that they also activate these points and be able to detect any active cases. But with our initiative, we call Partnership to Accelerate COVID-19 Testing in the Continent, we are also working tirelessly to ensure that all those who need to be tested are tested and they are either isolated or they isolate themselves and prevent any further transmission. So the key challenge and issue that I think will need to be discussed here and as we come to African continent, one of the thing is especially when it comes to technologies, and that there's been always a challenge, is one, the issues of data securities that whereby, for instance, as Africa CDC, every time we want to deploy any platform in the continent, one of the key issues will be you have to make sure that, first of all, as we speak of the Africa continent, also we need to recognize that it is formed by individual sovereign countries, that each country is independent and they have the right of information, right of data, and the right of protection of their information within the boundaries. So that's number one. Two, there's still limitation in terms of people who can access phones. Second, people who can access phones that are smart. And third, also those who can access phones and phones that are smart, being able to access the information, for instance, like the information that you have here for the apps, etc., to be able to download and how to use it and get enjoy the capacity or the capabilities of such tools, such powerful tools. So this requires a lot of advocacy, a lot of training, a lot of engagement with different stakeholders from the community level to the government level to be able to apply all these tools and technologies that are plenty out there, but are not well or fully utilized within the continent. So it's a good dialogue, and we're glad to contribute at Africa CDC to make sure that also such innovations, technologies, and are contributing to the control of the pandemic, and ensure that we also save lives while we're trying to also save the economies and the livelihood within the continent. Over to you. Thank you very much.
Thank you, Justin. It was great to hear how you're allowing the innovators and supporters from member states and partnerships to accelerate response to this pandemic in Africa. And thanks also for shedding light on the key challenges on the right of data and information and access to funds, and of course, access to digital technologies. This is what we're here to talk about as well. On that note, I would now pass it on to our third keynote speaker, Ko George. He's a professor at University of Cape Town, and he's also a co-founder of COVI-ID. He would be taking us through contact tracing without smartphones with COVI-ID. Over to you.
Thank you, Deepti. I hope everybody can see my screen.
Yes, we can.
Yes, we can.
Okay, very good. Awesome, thank you. So thank you so much for including me here. I want to talk a little bit about COVI-ID and the experience that we have in building digital contact tracing solutions for people without smartphone. And while it sounds like a oxymoron, there's actually some deeper thinking behind it. Let me just set the stage, and then I tell you what the solution, then I tell you why the solution is important and why the collaboration with PathCheck is so important for us. The key to successful digital contact tracing is simply collecting a large number of actual contacts, of actual physical exposure of two people. Google, Apple exposure notification and smartphones have a huge advantage because with them you can build a privacy preserving solution as PathCheck has, that respects sort of users' privacy and at the same time gives the necessary functionality to implement successful contact tracing. We know that in order for contact tracing to be effective, we need to identify around 60% of patients as soon as they have symptoms and contact 50% of their contacts instantaneously. That's research coming out of Oxford, where they show that if we take even 3 days or 2 days to react, which is not uncommon in the African context, where in South Africa we had a largely manual contact tracing effort. It easily took 2 in exposure. And at that time, it's almost too late to have a significant impact on the disease. Yes, you will make it a little better if you can trace some contacts, so every little helps, but in order to be absolutely effective and quell the disease, you need to actually have a certain speed and a certain width of who you include in this. So what we have built is a platform that works mainly through QR codes. And the idea is that users, as they go from one place to another, they have a QR code either on their smartphone if they have one, or printed on paper, laminated, you know, very low tech. They have a smartphone and they go to places where there's someone with a, they go with their QR code to places where there's someone with a smartphone that scans the QR code, and upon scanning the QR code, issues what we call a geolocation receipt. So what happens at that moment is that the person who verifies the QR code issues a receipt where that person with the QR code has been and when. So it's a little bit like all your tax receipts when, you know, tax season comes around. You get the shoebox where all the originals and the receipts are in, and you keep that safe for when you need to remember what you can deduct. So if there's a user that tests positive for COVID-19, our platform allows a manual contact tracer to contact that person and then ask for the geolocation receipts. So in that contact tracing interview that we think still needs to happen to get things like context, duration of exposure, in that manual contact tracing interview, the contact tracer can ask for the geolocation receipts, and if the user volunteers them, then the contact tracer can, through the COVI-ID platform, contact users that have been exposed to this user. And this can even work for people who don't know each other. So it's very, very similar in the way that the BLE function works in sort of just checking for physical proximity. Here it's the same thing. It's only physical proximity at the same time that defines an exposure. The way that we've built this platform is privacy preserving, and that was the main challenge in what we did. It's very easy to build a system that does what I just described, but that doesn't provide users with privacy. Now, we've heard just before the importance of giving nation states sovereignty over their data and give users, maintain users' human right to privacy. in fact, without that right to privacy, the adoption of very limited. And we see this in South Africa at the moment. The government launched a BLE-based app very recently. The president announced it and said, you know, it's an important part of our crisis response. And still, at this point, less than 1% of the population has downloaded the app. There are several WhatsApp groups spinning conspiracy theories around how that app will be used to monitor everybody's movement. So adoption is very low, and part of that is that people don't trust privacy. So what we have done is we've built this privacy preserving solution by using trusted execution environments. And that trusted execution environment is one of the very, very few ways that exist to actually have at the same time full privacy, meaning that every user is in full control of their data, and nobody, not even we as COVI-ID, as the operators of the system, have access to this data except for one purpose and one purpose only. And that purpose is the manual contact tracing interview. When a manual contact tracer can request access to a user's data and needs to type in a one-time PIN that the user gets sent when the contact tracer requests access. And only if the user provides this one-time PIN to the contact tracer, this is the active consent, only then the geolocation receipts will be transferred to the contact tracer. So again, limiting the scope, who has access to that data, limiting what can be done with the data, and especially limiting what will be done with what can be done with the data. So for any other purpose. The system works in conjunction with other contact tracing efforts, and thanks to PathCheck's open architecture, which really is key for us to be able to contribute to this, we are able to complement existing contact tracing solutions. We have included a couple of other things like different statuses. If ever you wanted to have sort of health status, for example, for somebody who's COVID positive in case they are admitted to a hospital and are unconscious. We've heard from doctors several times that it would be very helpful to find out very easily and quickly if somebody needs to be isolated, or if you have essential workers that you need to get back to work. But I want to make a point, sort of to not take too much time, but I want to make one point on the importance of having different solutions collecting contact data. And that is a simple math problem. When you look at how many people do actually need to download your app in order to be able to trace contacts? In emerging markets, you hit a hard problem, and that problem is in South Africa, 55% of the population do not have a smartphone. Full stop. It's not about adoption among them. It's not. So if you look at the social network like this, where each dot is a user, and the connections are sort of physical exposure that could lead to the transmission of the virus. And we have one lonely guy up here. So when you look at a normal social network like this, and you suddenly have one person with who tests positive for COVID, and then you take into account who has smartphones. So in my picture, there are some people who have sort of thicker lines and are gray, while others have thin lines and are not colored. So when you take into account that only 40% of the 45% of the population has a smartphone, and you start counting how many of the connections between smartphone users can you actually capture, you very quickly realize that the number of connections that you capture with a pure smartphone-based solution is exceedingly low. So in this case, out of the 4 connections that the user who is infected has, only one of them has a smartphone. So only 1 out of those 4 actually gets captured, while the other 2 are still exposed and have the potential to transmit the virus further. So this is one of the powerful mechanisms through which the viruses are being transmitted in these social networks. So only if we find a way to collect information about the social contacts between those with smartphones and those without smartphones can we get a sufficient fraction of contacts to actually make an impact on disease transmission. And this is key in reopening the economy, because unless we have herd immunity or a vaccine, both of which in Africa will take time, and if we go the herd immunity route, there will be devastation in terms of loss of life associated with it. We need to have different approaches that complement each other. And the problem with Google, Apple in particular, or with most of the national solutions that we've seen out there, is that they are built like a product. And what that means is that they are built for one purpose and with one controller, one company operating them, one company controlling what kind of innovation can connect to these systems and what can't. On the other hand, what PathCheck has done, which I think is absolutely key in an efficient response to the crisis, is to create an open ecosystem by doing the difficult work of creating sort of APIs that allow us to interface with other solutions, that allow us to connect different products and projects, and do that in a way that can be bottom up, so that people like we coming out of the University of Cape Town, sort of knowing the reality on the ground through a lot of work we're on just not having smartphones. And we know that there are few ways you can deal with it. QR codes might not be the best, but it is one way that people easily understand, and that would require sort of government buy-in to roll out, but that has a chance to actually be effective and complement other data sources. So these open ecosystems, in my opinion, are absolutely key in our crisis response. And I just wish that there were sort of more companies, more organizations following this approach, connecting to one another and making sure that the best solution gets deployed in the right circumstances. So with that, I think I'll end here, and I'm looking forward to the discussion. Thank you so much.
Thank you, Ko, for taking us through the COVI-ID solution and its partnership with PathCheck. It's great to hear insights on how a low-tech solution like COVI-ID can be such a simple and potential solution in the current pandemic scenario, and make the solutions more equitable while also maintaining privacy. Thank you. Next keynote speaker we have today, Mark Tristan from Global Fund, and we are looking forward to him speak about the use of data analytics and connected testing and logistics and vaccines, and also the people-centric solutions surrounding this topic. Over to you, Mark.
Hello, everybody, and my apologies not having beautiful slides like everybody else has. I'm going to be speaking a little bit in response to what everybody else has spoken about here. I work for the Global Fund. I'm manager in our IT department of analytics. And I think there's some key points which have come up here, which relate perhaps partly to how the Global Fund operates and what it does, but then more broadly about stopping and thinking about the role of data and technology in our analysis and response to this in general. And I just want to pick up on the points made by the two previous speakers. I think number one being that there is no single best of breed approach which is going to help to resolve this. I think if we look out to the experience of digitally native countries where we have wide smartphone adoption, and there have been track and trace apps which have been delivered. I'm a Swiss citizen and a British citizen, and I know neither of them has been particularly successful in their implementation of the track and trace technologies with the smartphones alone. If we look at it, the levels of adoption, people downloading apps versus high levels of smartphone ownership, that's a very different situation. We have 80 to 90% and then more smartphone ownership, but then still only 6% of the population downloading it. And that number actually using and going out and about with it is very different to where we're looking in a situation where we have 55%. So I think having a multiple perspectives on how we gather the ground data from the bottom up is really important. So looking at QR codes, looking at the ideas of geofencing, how can we basically gather data which is either digitally native or can be rapidly digitized to start to understand both location, movement, and risk associated with those items is very important. And I think Ramesh made a very key point at the beginning in terms of the digital ecosystem, that one of the key points in here is the idea of interoperation. And I think on this side, just to be very clear, that meaning things which are able to have the same conversation with one another about the same things. And this is really important because already it's very difficult. We can see that understanding and being able to visualize what's happening is very important, and COVID has a number of features. This is a high dimensional space, to use the math sense of this. We're looking at a lot of different features which can change both the responses that can be taken. So a country with an aging population versus a country with a more youthful population is already one area of these things. But we have a whole variety of features, some of which are well understood and some others which are very limited understanding. So one of the key items is to be able to, one, collect the data and have broad coverage. I think, as the two previous speakers have mentioned, use different techniques and technologies on this side. But the second one is to be able to build a connected picture by putting the pieces of this jigsaw together in a way that we can understand the overall landscape of risk. So in order to do that, this means it's not single apps, it's different approaches, and these different approaches being able to talk to one another, and this data being collected and gathered, handled in a privacy preserving manner, in an ethical manner as well, but also in a way in which the data can be aggregated and made available to other parties. So this is another key one, which is the distribution side. I think just thinking about this is where we get the first thing, which is we need to understand what's going on. We need to be able to identify where we have opportunities for interaction, which is either risk areas or places where we can go and cover this. And this is being very important for the Global Fund because we're effectively a response mechanism. You know, we're delivering out funding requests, making sure that funding can get delivered, understanding effectively what the funding should be used for, and making sure it can be delivered from a logistical perspective. All of these things mean that we need to be able to prioritize the response mechanisms that we put into place and make sure that those can adapt over time. And that can have impacts in terms of understanding how can we get to the point of need as quickly as possible. So this could be thinking about, as we move out to the other end, thinking about analytical models for vaccination optimization. I think we were talking about it a little bit earlier, but are there ways in which we can move beyond the single camp view of the world to starting to think, how do we hit these, given probably early on we're going to be getting low efficacy vaccines, and we probably need to make sure that we get those into the hands of the highest priority populations. We need to be able to make sure that not only can we identify those populations, but we can get to them and we can make sure we can get this stuff out to them. So that really, if we think about it, is then we have this data that we're collecting in terms of on the floor and understanding as to where there may well be the risk, but we need to be able to connect that up with the data, which is all of our response data. So that means effectively, you know, being able to know and understand how to apply funding to these areas of risk and cover these things across. So, you know, without overcomplicating things, I think it's really important for us to understand that we can look at point solutions in the one area, which may well be track and trace, or which may well be about vaccine optimization and everything else. But the key thing is to make sure that this ecosystem view is very fully supporting this overall mechanism. You know, the Global Fund is in the business of responding to 3 key epidemics. And now what we're finding is we're being impacted by this 4th one. And there are some comorbidity factors in places as well. It interrupts already our underlying operations. And what we really need to do is have a big picture to be able to respond to those. So without getting into the real technical detail, because I think there's a vast field of opportunity in here, one of the key areas that we need to concentrate on is supporting the right sets of approaches for gathering the on-the-ground understanding, supporting those and making sure that we can help sure that those are put into place, making sure that the information that we get gives as good as coverage as possible and can be connected entirely together. And my apologies just for my pauses there. I was getting lots of emails coming through at the same time, which is interrupting my speech. It's the joy of us living in a connected world. But I think putting this together and then making sure that we have this flow of the data and pushing into our analytical response mechanisms and things as well. I think this is really key for us to be able to respond in a full manner. And we're some way off that, I think, in terms of our base operations. So I think this is a good opportunity for us to really apply some effort and stop and think, not just what's the best of breed, but how do we apply this best of breed app or this selection of best of breed apps? How do they make them talk to one another? How do we then make them talk to our logistical information, to our testing information, to our vaccination planning, and to our funding information to make sure that we can deliver something out in an appropriate manner? So back over to you, Deepti.
Thank you, Mark, for talking about the role of data and analytics in this current pandemic and the importance of gathering data from ground up and building the big picture. It is certainly a very data-driven pandemic, I must say, and one of the key ideas we've talked throughout here is about the interoperability of data and understanding the opportunities for interaction, like you said. And you're spot on that we need to be thinking on prioritizing the response with the right data analytics and designing solutions for the right populations and supporting the right set of approaches is really key here. So thank you so much to all the 4 keynote speakers today. As a group of experts in the audience today having expertise in digital health and digital innovation in Africa, we would like to invite you to the roundtable for this MIT program for trusted pandemic technologies. And we would like to hear your views on designing solutions that would help public health professionals and leaders of government and industry to overcome barriers to engaging citizens in digital solutions in fight against this COVID-19. The discussion we will have now are around 3 key topics. One is travel and contact tracing, then there's testing and vaccines. I would invite now Dr. Ramesh Raskar to lead these conversations with you all. Thank you, Ramesh.
Thank you, Deepti. And it's just wonderful to have this very rich conversation. We have some really high-profile panelists who have joined us with deep expertise in this area and many entrepreneurs who are already in this space. So I'll ask the head of MIT Africa program to individually call some of these panelists and hear their comments first.
Sure, thank you. So again, very appreciative of you all being here. I think I'm really curious, Mikala McKay, to hear your response and also learn about what the Directorate of Science, Technology and Innovation in Sierra Leone is doing, and sort of any general comments you have about what you've seen today. Mikala is the Chief Operating Officer of the Directorate of Science, Technology and Innovation in Sierra Leone, and I know has a broad mandate to provide digital responses to many challenges. And, you know, as COVID came upon us, this was certainly one of them. So Mikala, if you just speak for just a few minutes about what you've been doing, and I think we could learn a lot from it, and also any responses you have to the keynotes.
Thank you very much. It's an honor to be a part of this discussion today. As we have seen, quite frankly, there is the need for us to be using systems and applications primarily to be able to gather data for analytics, to be able to inform policy decisions on response mechanisms to be put in place. One thing the SDI has been doing as lead for the ICT pillar in the COVID response is firstly to be able to understand our ecosystems. Now, as with many other countries in Africa, whilst we do have a large percentage of the population having access to mobile phones, a very small percentage, probably 15%, would have access to smartphones. So it's very important for us to be able to understand how we could engage the public in not only having information on COVID and COVID-related matters, but how can we collect data from the general citizenry, which is very important in ensuring that our solutions are citizen-centric. So for us, firstly, information flow was really critical. So we had to tap into low-hanging fruits like USSD and SMS services to ensure that the general population could be able to have access to things like, you know, basic tips and information or symptoms and updates on the COVID pandemic in Sierra Leone. At the same time, on the other hand, we've had to be utilizing high-end technology, for instance, working with partners like MIT GovLabs and FlowMinder, you know, a few other stakeholders, see how we can use core data records and maybe toll road data to do analytics on and be able to understand the mobility of, you know, generally speaking, be able to see how we can do predictive analysis of you know, where there's likely areas of spread, so that at least the government could take critical decisions on lockdowns, you know, if the need arises. But even from the drone surveillance that we did during the few days of lockdown we had, it gave us a very clear picture that Sierra Leone, unlike many other territories, could not do a national lockdown for very long periods of time, because we had situations where citizens could not have access to basic utilities, for instance. So it was difficult to keep people confined in a particular space. But again, zooming down into the track and trace for Sierra Leone, it has been, the process itself has been very manual. For obvious reasons, you have to have access to the devices on which these applications have to be deployed in the first instance. So it's a matter of having a positive case, listing the primary contact, and from that primary contact, be able to list, the secondary contact. So it has required a lot of reliance on humans to be able to do door-to-door tracking and tracing, and most of the time we had to go into short periods of lockdown to ensure we can trace people, because obviously people were moving from one location to another. So we haven't had the opportunity to benefit from digital track and trace systems. However, and again, the pandemic has created a lot of opportunities for partnership. So Sierra Leone, just a couple of weeks ago, we actually have signed up with Oracle to be a beneficiary of the Oracle Health Management System, which would now be helping us trying to capture data, at least on an individual basis, insofar as vaccines are concerned. And these vaccines go beyond COVID related, because what we've had thus far is very much so aggregated data that has been pushed into DHIS2, but at least now we'll have an opportunity to be able to collect individual coded and secured data insofar as vaccine is concerned. So just in a nutshell, this is what I would stop here for now and respond to any questions that I might have.
Does anyone have any immediate questions or feedback before we move on to our next panelist?
Yeah, I just had a quick question to Mikala about your thought process about vaccines. I mean, it's different than traditional vaccines or flu shots. So is your government, is your country thinking about, some kind of a solution for individuals? It could be very low tech, like, just having ink on their fingers to come back in 21 days or something that's digital?
Well, yes, as I mentioned, we are going to be taking full advantage of the opportunity that has been presented to us to now have the digital, vaccine registration system. Prior to Sierra Leone being hit with the pandemic, we didn't have, any strategic plans as such to digitize the capture of individual data registry. What was done, in as much as it was digital, was on an aggregate level. So now with partnership with TBI and Oracle, we would be beneficiaries of a full-scale digital registration system. We have, however, before had situations where efforts were made to see how this information could be captured digitally, but due to funding and other challenges, lack of coordination, it didn't really map out as planned.
Yeah, I think an interesting conversation would be to use many new startups and organizations that are trying to create digital IDs using face recognition and things like that. And maybe, the next meeting we have for MIT Africa, we can bring some of those partners to see, because, vaccine delivery has always been very challenging. And if we want to finish the whole process in a matter of weeks, it's going to put a lot of strain and create lots of confusion.
Okay, thank you. Any other comments or questions for Mikala McKay? Okay, thank you. So let's now turn to Dr. Jacobovits, who is the co-founder and CEO of MDoc. I believe she's in Lagos right now. Is that true?
I'm actually in Johannesburg.
Oh, you're in Johannesburg. Okay. I know you move.
Yeah, back and forth. But our borders open tomorrow, so.
Okay. Wonderful. Well, thank you for being here and joining us. MDoc is a fantastic partner of the MIT Africa program. So MDoc is a telehealth platform, and let me hand it to you now to discuss what MDoc is and how. I know you've been working on some very specific responses to the pandemic.
Absolutely. Thank you, Ari, and thank you, everyone. It's such a pleasure to be with you all today, really having this very important discussion. So as Ari said, my name is Dr. Nneka Mobison. I'm co-founder and CEO of MDoc, which is a digital health social enterprise that leverages behavioral science, technology, data, as well as quality improvement methods, so think Lean Six Sigma, to optimize the end-to-end care experience for people living with chronic health needs in sub-Saharan Africa, although our current target country is Nigeria. So essentially, what does that mean? We offer a high-tech, high-touch integrated care platform. So essentially, we have this nice fluidity between our digital platform as well as in-person, what we call nudge hubs, to support people with chronic health needs such as diabetes, hypertension, overweight, obesity, mental health, as well as pregnant women with self-care support. So historically, we've said, we supported people the 99% of the time that they were out of the facility. But what we also did in terms of creating this integrated care platform is that we had to build navihealth.ai, which essentially is a geocoded directory of healthcare services, facilities, and providers, so that we could help navigate our members on where to go for in-person preventive and promotive care when needed. But we also had to integrate teleeducation for providers as well, because we wanted to increase the likelihood that when our members would go to facilities, they would get the right kind of care in the right manner at the right time all the time. So in the context of COVID, the very people that we essentially support were essentially clearly at the greatest risk, right? So people with chronic disease, as well as pregnant women. And so literally overnight, we went from kind of that 99% of the time that you're out of the facility to providing what we were calling 100% self-care supports and care supports, having to expand the breadth and depth of our services, such that while we were doing a lot around educating, helping people understand the risk and what they could do from a self-care perspective, we essentially had to build virtual capacity. Our focus was, how do we keep people out of the system that don't need to be in the system? How do we work with facilities to help them navigate where to go for testing and where to go for care? But increasingly, we then also had to advocate on their behalf so that they would receive the right kind of care when they got to facilities. And so what we learned, and what we've learned along the way, and these are considerations, I think, as we all have this conversation about digital contact tracing, is what happens beyond the phone, right? When we think about privacy, and I think these conversations around privacy are very much, they're at the phone level, but what happens beyond the phone? So we had to literally day in and day out help people who were concerned about their risk or concerned that they had COVID, help them understand where to go to get tested. But a lot of times those conversations, to even have those conversations with our coaches, had to happen outside the confines of their homes, because they live in high dense communities where high density communities where people could hear them, and where they were worried about the stigma associated with it. We have to think about it from the perspective of kind of the end-to-end aspect of what happens once you know that you may have been exposed. Is your end-to-end care, or kind of the end-to-end continuum of care, is that going to be handled in such a way that there are very few barriers for you along the way? People didn't want to get tested who were worried, because in the early days, ambulances were coming to pick people up, and people didn't want the stigma associated with being seen to be positive. We had many of our members say to us, complain of anosmia or other symptoms, and we had to spend literally hours supporting them to actually go and get tested, to help them overcome those fears. But at the center of it, I think we're concerned about the rest of the community knowing, right? But also what would happen when they got to the facility. So just very much around how are we thinking along the continuum when we think about privacy? And then also, how are we thinking about it from a gender lens? I think COVID for us underscored how limited decision-making authority is for women in our context, the low-income women that we serve. And we increasingly had to advocate for their behalf with their partners, with their families, and also with health facility workers. So how are we thinking? And also in our context, about 80% of our members are women, 79% have smartphones. But even for the smartphones, a large proportion of these women share access with other members of their families. So how are we thinking about privacy and digital contact tracing when phone ownership is shared?
Yes.
And what?
Yes.
Okay, go ahead. Go ahead.
I think these are such important points you're making, Nenka, and especially this issue that COVID-19 might remind us, but these are very entrenched problem in the society, and very proud to hear how you're focusing on the maternal health and women's issues as well. Also, we're fortunate to have Emmanuel here from CDC Africa, given you're also working in the same space. Emmanuel, do you want to introduce yourselves and share with us your thoughts on COVID-19 and African response? Go ahead, Emmanuel.
Emmanuel is CDC Nigeria.
Okay, hello, can you hear me?
Yes, go ahead. Go ahead, Emmanuel.
All right, good afternoon, everyone. It's about 4 p.m. Nigeria time. So I'm from Nigeria Nigeria Center for Disease Control. Unfortunately, I'm sure there will be a lot of background noise because I'm in the EOC. So just in a brief, what I'd just like to mention here, thanks for having us on here. With regards to digital pandemic, in these times, really, the concept would be for us to consider sharing data sharing really, and making it real time. And this responsibility ought to be considered for global good.
We're hearing a lot of noise in the background, Emmanuel. So we'll come back to you. There's some background noise from your computer. Let's move on. Do you want to? Should we invite Hoda from Tunisia?
Yeah, please, Hoda. We'd love to hear. You know, as a professor and an innovator in the startup space, working with many digital innovations and enterprises, particularly focused on life sciences. Just curious what you've seen and what the response has been in Tunisia, and how some of people in your innovation community are responding and thinking about these challenges.
So Tunisia was a very specific case. Firstly, it belongs to, I mean, in Africa, it was one of the countries that really succeeded to slow down the contamination from the beginning. The numbers were strikingly positive, in the sense where by end of February, everything was in lockdown and the numbers were really, we didn't have much contaminations. But strangely, at the same time, after the summer, Tunisia is now facing the real COVID situation. So what we have seen essentially in Tunisia, I'd say two main, and without entering in the details of specific startups, but I'd say there are two main trends. Firstly, we've seen for the very first time an incredible collaboration between the government and the startups. So there has been a governance. The innovation was more in the way the governance was organized. So there was a task force with the government and including all types of startups that had inventions that could serve the country. So for instance, identification of people, localization of people who were contaminated, and also other solutions to better organize the logistics and operations. The other dynamic, I'd say, is that startups had pivoted a lot, adding many activities to make sure that they could respond where the government did not have enough resources, whether it was in, for instance, the delivery of medication for people who were sick back home, or also for the transportation of sick people who didn't have ways to commute. And I'd say also that what we have seen in Tunisia is a lot of communities that were integrating and supporting startups in a very volunteer way because they were supporting COVID. So right now in Tunisia, I would say that the difficulty for us is that the reality is that it's happening now. So what happened and all the responses that occurred in your countries in Tunisia, I would say that for us, this is the very first COVID strike in our country.
That's fascinating. Does it mean that that the kind of the public-private partnership will be a way to go? Because in many countries it has been a top-down solution.
So I'll tell you.
Your comments gives me hope that there may be an opportunity to use innovation entrepreneurship in this.
Yeah, 100%. So my comment here, and I think that and maybe I can send some documentation later on, but Tunisia has been the first country in Africa to have a legal framework that has been developed in a very, very bottom-up perspective. It took 3 years to entrepreneurs to go to the parliament and defend the law that they wanted to create, and the parliament said yes. So what happens in Tunisia is that despite all cumbersome administrative aspects, when it comes to innovation, the government fully trusts startups, and they always have this governance method where you have public-private partnerships that work extremely well. For instance, we have created a law that gives labels to startups, and that the committee that's in charge of that is composed of probably a third of the government, and 2/3 are entrepreneurs and people from the ecosystem. So the public-private system in Tunisia is the only way out. I don't think that we have another way to implement without this partnership.
That's amazing to hear. Ari, maybe we should, as part of MIT Africa, maybe we should host an entrepreneurs panel next time, because the ideas we're hearing on this panel could really change the way we're thinking about this epidemic. Emmanuel is back with a better voice. So Emmanuel, welcome back from CDC Africa, CDC Nigeria.
All right, thank you. Really sorry about that background noise earlier. I'm sure the sound is better now.
Yes, it's great.
All right. So I was saying, Emmanuel Benyogo from the Nigeria Center for Disease Control. Really, it's a pleasure to be part of this conversation. Good enough with following with the MIT Africa COVID-19 Challenge Hackathon, and had to support the COVIStics team. I've been providing mentoring with them after the event, and I'm sure they've made progress. It's been such an intriguing time for us here in Nigeria. We have had to digitize, say, 100-fold. We are currently using the Surveillance Outbreak Response Management and Analysis System, which started off in 2014, and in 6 months into the outbreak, we have been able to deploy in all states of Nigeria. This is something that didn't happen before now. And the concept really is about having real-time data. It's really very interesting to hear that we're considering interoperability of data sets. And this is because several government agencies or several organizations have had some sort of data collecting tool that have existed before now. But how are we able to not introduce something new? Because the typical setting in an African or in a low middle income country is you will find a data collection point having several devices from different organizations. How are we able to think through already existing systems speaking to each other? This is something that has been very at the core of what we did here, and good enough, one of the challenges that has happened as listed here, contact tracing, laboratory, and then newly vaccine. So we've had to see how can we, so the major problem that we had was you collect sample. First of all was identifying the cases. Now you've identified cases, you've collected samples, tests have been done, but the people don't get their results. That's majorly the problem. So you find out that, oh, a sample has been collected a week, 2 weeks. People are complaining that they've not seen their result. Not that the tests were not done. Most of these tests were done around 24 to 48 hours, but people did not get their results. So how do people get results? And then somehow we've piloted in 2 states, that's Lagos and FCT, where and it's still through the same platform. So what the point here is whatever it is you are thinking, whether it is the private sector, whether it is government sector, if it is partners that are bringing it in, is trying to leverage on already existing systems. So there is already a surveillance system in any state or country you go to, but you have a solution, some sort of this contact tracing solution that's looking into Google AI and having to match people with the Bluetooth low energy devices, speaking Bluetooth handshakes and all of that. The already existing system, how can we plug into it such that we're not introducing another device to the data collection point? So I'd written this out. It's basically about sharing timely data in an open manner with minimal political interference. The minimal political interference is another major key point there. So it will be also something to consider in this in these decisions as we progress. I'm very happy to meet a couple of colleagues here, and I'm up on time. Thanks very much for having us.
Those are very interesting point, Emmanuel, because the notion of data creates knowledge creates wisdom, and from wisdom we can make actionable impact. But your point that the data should come from sources we already understand, I would say that using smartphone and feature phones and what Coach George talked about, even using QR codes, can create data that's bottom up, where people are and what people are doing. And as long as you can create in a privacy preserving way that does not lead to a surveillance state or doesn't discourage people who are the margins of the society to participate, I would imagine that also creates a completely new data source. And the good news is that you can collect data from smartphones in a completely privacy preserving way. And the Google Apple protocol is one solution. PathCheck Foundation has another solution. Coach George has another solution. So we just live in a new world where we can actually get kind of in the banking grade privacy, without having to worry about creating a big brother state. So that's kind of exciting for me. Go for it, Mark.
I was just going to pick up. I think I back channeled you a little comment, but I think Emmanuel's comment also picks up on this, as well as the MDoc speaker's comment on this side. I think we shouldn't be thinking about data collection. We should be thinking about, it doesn't exist. It's not sitting out there that we can just come and sort of and fish for it. It's something which is more a communicable medium. And I think this is the key thing where I think the comment was where to get tested, for instance. And I think this is a very important one as we look across the experience of other countries coming around here. There was a comment about patients needing to go into facilities. Well, let's stop and think about the facility availability, the swamping of facilities that we've seen in certain places. What we need to be able to do is not just identify what facilities can do what, but make sure that we can see the data about what the availability of those facilities are. You don't want to be sending somebody off to testing. I think it happened in the UK, for instance, where people had to drive hundreds of miles to go and sit for hours in traffic jams because there was no availability on these things. So I think the key thing is to stop and think about the continuum of responses that are required on top of this, rather than, we need to track and trace when we do these things. The whole thing is what are the variety of actions that we need to take as we collect through the data, and where can we cover them? So it'd be fine for us to have broad testing. But one of the other things that's been seen, I think, in France, for instance, where there was a lot of testing, but then people were waiting 7 to 8 days to get their results, and they weren't isolating, so they were going to and spreading this. The one thing that the Global Fund has been doing is background deal making for our central procurement to get the Abbott tests and the other rapid tests so that they're available and out there, so that results can be delivered out nice and quickly. So this is the key thing about, okay, where's the point of need? Where's the point of need to get tested? Where is there capacity to get tested and no danger of additional transmission? Can we get the results and the data back on these things? And it needs to be a big round trip of these things feeding into one another and conversing, because that's an ideal state. I don't think anyone is going to get there in any country individually across the way. But the more we can pick out on this, to Emmanuel's point about it all talking together, I think will be a good one. Huh?
Yeah, very critical. I mean, and I would imagine, Mark, that also applies to vaccines and not just tests as we move forward.
Vaccines as well, obviously, stopping and thinking about, as we said before, the point of need, thinking about, looking in a data science way, looking at the distance that somebody needs to travel in order to get these, or minimizing the time that's required to get them out, because time is critical, because it's transmission time, and so on and so forth. So yeah, absolutely, it's across the border.
I mean, never in public health history have we, vaccinated 7 billion people with a new vaccine in less than a year. So it's going to be, a pretty messy process, unfortunately. And we need all the digital tools and support from citizens without infringing on their freedom to get this going. I see Spectra from PathCheck Foundation, who's a very MIT graduate, but also very familiar with the African context. If you're online, would love to hear from you as well. And then Ari, we also have a couple of other guests if you want to call them on. And then let's in a couple of minutes we can transition over to two topics that have come up, which is travel and coordination of that.
Thanks, Ramesh. Hi, this is Spectra. I'm very proud African and really excited to hear all the perspectives here today. I'm really, really inspired. I have a sort of maybe more of a philosophical question for Nneka and then also Emmanuel, just given your comments about data and just encouraging different behavior. And so one of the things that I was thinking about specifically, Nneka, was you mentioned that your platform, is, it's a digital platform that is basically consolidating or driving coordination across the different facilities that people might visit from a health perspective. But then also you've got coaches who are, it seems like the primary source of nudging and behavior change to drive people to those centers and to then advocate for them while they are receiving healthcare. And so my question is more so, given the behavioral science background and aspirations, in the sense that we want to be able to track and understand what encourages people to seek out healthcare, what prevents people, what their barriers are, but most of those conversations appear to be happening in person. It's also connected to something that Emmanuel said about, sort of how culture and the landscape and even political interference plays a role here. So most of these are happening in conversation. So I was curious, I'd love to hear from both of you, maybe Nneka starting first and then Emmanuel, how you are capturing, or I guess, structuring some of those insights and information you are receiving from these in-person conversations so that we can leverage technology and actual digital, so data, to, which we can collect at a larger scale to make a better decision. So just curious your perspective on that, given the limitations in data and technology driving behavior in Africa.
Yeah, Nneka or Emmanuel, any thoughts on that?
Thank you, Spectra, so much for your comments. So, so what we use a digital platform. So we've created kind of this digital platform for basically both members as well as coaches to document all of this information, right? And so we've structured our database so it's you're able to actually analyze this data. I mean, ultimately, we're not doing predictive analytics yet, but we have a plan to. So we're very intentional around kind of how we've structured our database. So we're capturing what it takes, right, to actually even build trust. What types of nudges seem to be working to help people actually start trusting us, quite frankly, before they even trust the system, and what's required to lead to actually lifestyle modifications or care-seeking behavior, and ultimately outcomes. So we track literally end to end. We're tracking even is the person alive? Is the woman, I mean, we've seen, to be very frank with you, in even the people that we support, higher numbers of stillbirths, miscarriages, neonatal deaths during these COVID months, right? And it's directly linked to kind of what happened at the facility. So we have it completely in our digital platform. So you're right that we're doing a lot in person, but I'll tell you, especially what we've been able to do, it's a multimodal platform. So dual way SMS voices I highlighted. And so through that integration, and we meet people where they are. It's also Telegram and WhatsApp that we've integrated into our platform. And so by doing that, we're actually able to capture every element of kind of, what we're doing and what they're doing, so that we can understand better what interventions need to be made along the continuum of their care that can improve their outcomes as well as, and their behaviors ahead of that.
Great.
Okay. Yeah, thank you, Spectra, for that question. And just writing on what Marquet has said. Basically, I'd give this very simple example. So in the response structure currently, we have a pillar or a function, an operations function called the risk communication. And that team is able to do all sort of ongoing assessment, trying to assess how are people perceiving. So initially when this outbreak started, and that's another way trust has been gained. Initially when the outbreak started, it was more around, it's not real, it's not in Nigeria, it's not happening. And then a notable person in government gets infected and we lose the person to COVID-19. And then it hits some people like, oh, really? Oh, this is happening. Okay, no, it's not happening. Initially, it's not happening. It's not affecting blacks. Oh, now it's happening. It's affecting blacks. Oh, initially it's happening. It's affecting the high social class. Oh, now it's happening. So the risk communication team is able to harness this information and it's changing our messaging, the message design. So yeah, you might not see there in public. We have a Twitter handle, and we know how that Twitter handle has been bombarded and all sorts of infodemics, and then people who are coming there to say all sorts, but it has informed the response. And if you look at our responses from the beginning of the outbreak till date, you see that it is those in-person conversations are affecting. Once in a while, you have a subject matter expert go on air, take press briefing, take media appearances. We have the PTF that is taking questions every day. There's a situation report that is prepared every day, daily. Even till date, we still have our situation reports daily sent out. So the risk communications function is able to take these in-person conversations, and that is helping the conversation really. I'm certain it's something that is moving. In the digital space, we have the self-assessment on the COVID-19 website. There is that self-assessment tool that is there. I tried it once. I just said, let me even try this thing that some of these things we deploy, and that's what I do too. I tried it and I said I had a fever. Actually, I was having slight headaches, and I said I had a fever. And guess what? A doctor, and I'm sure I asked the doctor, I said, sorry, are you an NCDC staff? He tells me no, that it's a public-private partnership. So this is how we are leveraging on it. And a lot of people, because they just feel, oh, it's government is not doing anything. Another example is, initially during the beginning of the outbreak, we were sending SMSs and people were complaining, oh, don't send SMSs. That they should use the SMSs, they should stop sending them SMSs, they should send monies or as alerts to them in their bank accounts, and then we stopped. Guess what happens? People come back and say, where are the SMSs? NCDC has stopped. The only people that were sending us SMSs during the lockdown have stopped sending us SMSs. Please bring back the SMSs back. And then now the SMSs are a little more prone down. It's not every day, but they are more targeted towards effecting some certain change. And really, this is how these in-person conversations are changing the conversations. Thank you.
Thank you. Just a follow-up question to Emmanuel. Emmanuel, so quickly, Ramesh have talked about the PathCheck solutions, and Kopi has also talked about COVI-ID. Do you see these solutions being integrated into what you are doing at the
Okay, hello?
I think last time I think you meant to ask is, will this COVI-ID or PathCheck like solutions be a good approach for what you're doing?
So something we've done with every new. I think he's still trying to.
Yeah, I'm going to mute Dennis for now.
Okay.
That was
all right. So something we've done with every one of this new innovation is we do what we call just using design thinking and checking. Okay, what is already available? How is this going to solve the problem? And then it's integrated. So there's always that design thinking approach to whatever it is solution. We're always open to discussing these ideas, and yeah, contact tracing without smartphones, with COVI-ID, and then the PathCheck. Very interesting concept. So all we do is sit down with the team. Already existing structures are here. Design thinking, how that brainstorming session to see exactly what problem does this solve, and how do we integrate it into what's already existing. If something is already existing and provides same solution, we just compare. Is this better? This already existing one, can we improve upon it? If no, okay, can we replace this with it? So it's basically there's no silver bullet and say, oh yes, we take this on. It's always looking at, through a brainstorming design thinking session, what does this bring? What hole does it plug? And then how do we move on from it?
Those are some fascinating ideas. And Emmanuel, also realize you're right in the middle of the action. You're still working in your office with all your colleagues running around with the mask. So you're not just doing it theoretically, you're doing it for real. So we appreciate you taking some time. There's a question from Khalil, which anybody can take, especially those of you in the government, which is, who is making the decisions on technology? Are the people from the chief information officer or the IT department making this, are able to have their say, or is it more from public health? And to be honest, what we have noticed in many parts of the world is the public health folks and epidemiologists, as amazing as they are, get into an analysis paralysis mode that say, no, but what about this? What about that? What about people who don't have smartphones? What about this? And they end up doing nothing. And the IT people are more about, yes, we can, and they get started, but then eventually, once they have built a solution, they run into the bottleneck of trying to convince the Department of Health. So what are you guys, what are your thoughts, either Mikhala or Emmanuel or others on the call? What are you doing there in making sure the right people, group of people are making decisions versus the right group of people are helping but not blocking?
Okay. All right. Well, on our side in Sierra Leone, of course, the National Emergency COVID Response Center that was set up when we were hit with the pandemic, it has a multi-sectoral approach. So there are members from the Ministry of Health, Information, Communication, all stakeholders, and then we have respective pillars with specific functions. For the ICT pillar, in particular, really is a consortium, not only of local stakeholders, but also of public sector stakeholders, foreign partners that we work with. So what we do really is respond to the needs of specific pillars. So for instance, we had an issue like with contact tracing and case management, where they were struggling to be able to capture data real time on quarantine centers, whether or not these were government owned and controlled. So they would now feed that information to the ICT pillar, and we would now brainstorm and see how we can first of all look at what is existing that could be modified. And I think Emmanuel made quite mention of that you have to leverage on the existing and what we can build on, instead of rather just running to building new applications and solutions. So in that case, we now came up with a quarantine application that could help us to monitor real-time services that were being offered at the quarantine centers. So it's very important to identify the specialists insofar as the ICT experts are concerned, but at the same time that they don't work in isolation, or rather just think it's an opportunity to just run with any innovation or technology because it is out there. Understanding the uniqueness of your ecosystem is really critical, and consulting. So it is a continuous process of consultation to know the specific ministry or department, or even the National Emergency COVID Response Center, what are the needs you're responding to? So whilst I own that, if I could just make comments on the travel and the contact tracing. So when the airport was declared open for commercial purposes, a couple of months ago, the ICT pillar now had to come up with a strategy of collecting inbound passenger information before they come into Sierra Leone. We had to see how that could integrate to the Health Connect app that laboratory was using. So even before the flight is in Sierra Leone, all their information of who the passenger is, their passport number, their contact number in Sierra Leone, and even what they're using overseas was already captured at the database. So when swabs are collected at the airport, it's very easy to tie that passenger using the unique identification that they have registered with on the travel portal to link them to the Health Connect application and after which they would have the results sent to them via SMS or email if they are negative. But of course, if they're positive, that information is already pushed to the DHIS so that it's accessed by surveillance, and surveillance would be the first contact at those respective addresses, you know, to ensure that that passenger remains quarantined and under observation. So, you know, just to close on that, it's very important that consultation and engagement is continuous, and that the primary purpose is responding to the needs of that specific pillar to address the response.
That's fantastic to hear about your solution around the passports. Emmanuel, we'll come back to you. Just because we only have a few minutes left, I want to see if few other of our panelists, like Professor Lily Tsai or Chris Buchanan from MIDRA, just want to introduce yourself there. And also we have Kathleen Grivers from Africa EDU. We just want to say hello.
Hi, yes, I'm Lily Tsai. Thanks, Ramesh. It's been incredibly useful and interesting to learn from all of you. I have a lab at MIT, have been working with Ramesh on issues of trust in pandemic tech, and have also been working closely with Michaela McKay at DSTI, where Sierra Leone really has mounted an extraordinary response that is data-driven, even when it's a combination of analog and digital. So thanks, Ramesh.
Welcome. Chris?
Yeah, thank you. I am Chris Buchanan. I work for the MITRE Corporation, and I'm the capability area lead for digital identity, and currently focused on self-sovereign identity. We did try to build a self-sovereign, I guess you would call it a contact tracing call center using self-sovereign identity so it could scale. And I actually completed that prototype. And now this year, MITRE is standing up a platform for social justice. And I'm really interested in some of the offline opportunities to use the digital identity technologies that Cape Town has developed and others to be more inclusive in our research, because as you know, most people know, Silicon Valley tends to be very smartphone centric, and thereby excluding a good portion of the world's population from participation. So we're looking to help with that. Thanks.
Fantastic, fantastic. Anybody else I may start on before we wrap up? All right, so let's thank our panelists, and we'll wrap up our official session. You're welcome to stay on for private conversation after this. But Ari, let's take us home. I guess we have Deepti, Ari, and Dennis. Final thoughts, and then I have some ideas on what could be next steps.
Thanks, Ramesh. Reflecting on many of the things you've said, and sort of a bigger overarching theme is wondering how the response to this can be unifying instead of dividing. After watching the debates in the US last night, maybe some of you have seen them, and hearing about some of your responses, I wonder what can be learned about how we can unify. Maybe it's issues of trust, maybe it's issues of shared responsibility. And I think we get into all those topics, sort of what happens outside of the digital platform, and how we can work together. So that's what I've been thinking about as many people have been talking. And maybe it's because I'm sort of steeped in the American context of, frankly, our failure to respond, and the division we've seen. So it's been inspiring and interesting to hear your comments, and consider how we can leverage this moment for something, something that is an opportunity, something that is unifying. So thank you, and any other final comments?
Yeah, Dennis. And Dennis, by the way, is Harvard Kennedy School, as well as a medical doctor in Ghana. So he has been a longtime partner for us in this endeavor. It's unfortunate he has a poor internet connection from Ghana as he works in this.
Hello, Ramesh. I'm back now. Hello, Ramesh. Can you hear me?
Yes, almost.
Oh, good. All right, hello, everybody. I think it's been an amazing presentation so far. Sorry for my connection went off a bit. I'm Dennis Addo, physician from Ghana, working in digital health. Just graduated from Harvard and also working with PathCheck and MIT to implement some of these solutions. So I think it's wonderful, and we hope that we can work together, as everybody has said, integrate solutions together into one to make it work. Thank you, Ramesh.
Deepti.
Sure. So it was really inspiring and interesting to hear all these thoughts here and such amazing insights, definitely. And I have to say that it's true that data creates knowledge, and that converts into actionable insights, like we all say, and how interoperability of data is so important. But I believe it's also interesting to hear thoughts here from solutions like MDoc and Nenka mentioned about understanding the human-centered approach that is being generated, and how our solutions should really be the actionable insights can be converted into human-centric approaches only if we consider these elements. As well as Emmanuel, I really appreciated the thoughts that you presented there about these technological solutions should be leveraging more design thinking and design solutions really coming from the design aspect as well, and not just from the technology aspect. So really amazing discussions here, all the people, and thanks to all the panelists, and thanks to MIT Africa for helping us host this. And over to you, Ramesh, for your last words.
Yeah, so I think it's obvious that we have experts from north of the continent to the south here, or Tunisia to South Africa, and east to west, and a really kind of international partnership here with MIT and Harvard and PathCheck Foundation. So we hope to continue this conversation. Ari, we will get some thoughts. We'll try to get a report out based on today's conversation. I hope all of you can participate as a co-author to that report that we'll put on the MIT Africa website, as well as pandemic.mit.edu. So I encourage all of you to stay online for our private conversation, but let's say bye to our public audience.
All right, thank you guys.
Thank you all.
So you can